Welcome, folks. Thanks for coming to our February meeting of the Carolina Community Coalition. We are excited to have you and to start a new semester. We've got some fun topics on the radar for this spring, starting with opiates and medication-assisted treatment. We've got a great panel of folks here today. I will ask our folks who are attending if you can introduce yourself in the chat. That will give us a sense of who's here and what organization or office or area you represent. Feel free to also talk to each other and have conversation and cheer on our presenters and panelists in the chat as well. If you have questions for our speaker today and our panelists, go ahead and use that Q&A function that we pay Zoom some extra money for, and that will allow us to be able to make sure we don't miss your questions and our panelists to be able to ask, to answer when we get to that section. Thanks for all of that. And I remember to hit record. So I am going to go ahead and introduce our speaker first. Dr. Brady is Vice President for Research and manages all aspects of research at MUSC. She's known for her research in drug and alcohol dependence and on PTSD. Dr. Brady established the South Carolina Clinical and Translational Research Institute, whose vision is to improve the health outcomes and quality of life for South Carolinians by translating scientific discoveries into evidence-based clinical practices. And I got to tell you, I think that's so much of what our coalition is focused on this year, right? Is translating some of the research and theory out there in the world and figuring out how to apply that for our campus and our community in Columbia. So we're excited to have you. Dr. Brady received a bachelor's degree from Fordham University, a doctoral degree from the Medical College of Virginia, and her medical degree from the Medical University of South Carolina. So thank you so much, Dr. Brady, for joining us today, and I'll let you take it away.
Okay, thank you. And I'm going to just give, fairly brief, probably like a half hour, starting with just an overview of the opioid epidemic, overdose epidemic, what it is, how we got here, and then talk a little bit about treatment options and some of the initiatives that are ongoing in South Carolina. I'm looking forward to your questions and your comments and your suggestions. So please feel free to interrupt or ask about anything. So let me just begin. Now this is not advancing. It was before. I'm okay. Now it did. All right. Sorry. So the main point of this slide is that opiates have been around for a really, really long time. That really their use, I mean, it's a natural substance, not all of them, but when they were initially used, before the opiate use predates written history, 3400 BC, and really have been used. Now it's just not advancing again. I'm sorry. I wish I could. Let me just try remote control. No. I'm not sure. Oh, here, let's try this. Okay, good. Just to show some of the many formulations and ways that opiates have been used until 1923, when in the United States, when they were controlled by the first Controlled Substance Act. But before that, they were, opiates could be found in cough syrup, headache remedies, just all kinds of things. And they've been used, as we said, for centuries without necessarily having the wreaking havoc on society as they have done in the last 10 to 20 years. And this slide here just shows you what's happened. It's a heat map looking at overdose deaths in 1999, and you can see darker, more red means more overdose. And just look at the difference between 1999, where there was one little nidus in the Midwest, and 2016, where there's incredible density of overdose deaths. And it's done nothing but increase since 2016. In fact, in 2021, we had the highest number of overdose deaths in the United States ever reported, and it was over 100,000 deaths. So just think about how many people that is dying per day of opioid overdoses. It's really a frightening thing, a frightening epidemic. And so why do we think it's gotten so worse in the last couple of years? Well, we really think COVID-19 and addictions in general, but particularly the opioids, has been kind of the perfect storm. As we know, these are marginalized populations, both people who have COVID-19 and people, but marginalized populations are more vulnerable to COVID-19 and to addiction. So these are people that are sort of at the edges. They're underemployed or unemployed, often in homeless shelters. And because of all of this, they're vulnerable to the medical consequences of both COVID-19, and during the epidemic, less likely to seek care, not only because emergency rooms and other venues through which they might seek care were just inundated with COVID patients, and people really didn't make the time or the effort to really care for addictions. But in addition, those systems that we do have for providing care for addictions really became increasingly fragmented, especially when COVID-19 first hit. People have sort of gotten their act together, but you can imagine residential facilities with COVID-19, they ended up emptying their beds. A lot of, in the beginning of COVID-19, before we really knew what was going on, if you'll remember, places were told, unless they were providing essential medical services, asked to close down, and some of our treatment settings closed down. I mean, we had to convince them that they actually were providing essential medical services. So, our systems for providing care really did become more fragmented. But to even COVID-19 aside, how did we get here? Well, we got here because, number one, pain is a very, very, very common symptom of all kinds of illnesses. And you can see that Americans are reporting more chronic pain sort of across all age groups. And then, pain in like about 2010 through 2012, JACO and others said, pain is the fifth vital sign. You must ask about pain at every visit. So no wonder people were reporting more pain. And there was also even a reimbursement incentive when they were using patient-reported outcomes a lot and patient satisfaction. One of the main questions they'd ask at hospitals and others clinics were, was your pain adequately treated? So doctors became very sensitized to asking about pain in 2005 to 2010, and more aggressive about treating pain. So into that crazy atmosphere, we got a huge. That was really when Purdue and other companies began to manufacture opioids that were highly potent and highly addictive. And the interesting thing about OxyContin, and the reason Purdue got into so much trouble, is because their initial claims were, our drug has it's slow release and it has less abuse potential, when in fact it actually had extraordinary abuse potential, particularly if people took it in any way other than orally. And when people are abusing substances, often they'll shoot them up or they'll take them intranasally. And then it had a really rapid onset. And there was celebrity endorsement. There were all kinds of reasons that OxyContin became extremely popular. But I think what made things even worse was doctors. There was one article, but it was published in an extremely influential journal, the New England Journal of Medicine, and it was very flawed. Because it basically didn't follow people once they left the hospital at all. But it said addiction is rare in patients treated with narcotics, and showed some data. And you can imagine that every drug rep for OxyContin and other pain medications was carrying this in their, in their satchel and handing it out to doctors left and right. So we had misinformation. from both drug companies and from some of our most trusted sources of information, combined with an atmosphere of ask about pain, ask about pain. So, but, I'd say by 2012, 2015, it became pretty clear that we had a problem with opioids and that opioid overdose death was on the rise. And really, I'd say it was around 2010 that it became really obvious. And at that point, the DEA and other agencies, first of all, they started using these PDMPs, prescription drug monitoring programs. So every time an opioid was prescribed, it went into a central database, and DEA could find high prescribers, and they started shutting down some of these pill mills and that sort of thing. And what you can see is what happened is that people by this time, however, unfortunately, were dependent on opioids. It might have started with a chronic pain syndrome, but then that just worsened because every time you withdraw opioids, the pain gets worse, and then they would escalate their dose. And so what you can see that happened in 2010 to 2013, 14, 15, the number of opioids prescribed went down. That's what this graph is showing. And the number of synthetic illicit opioids that were involved in overdose deaths started to go up. Here you're seeing heroin, and here you're seeing other synthetics like fentanyl, et cetera. Those numbers have just gone up and up and up. So prescriptions are actually going down. They've probably bottomed out now. But while that was happening, some people, doctors, we talked to doctors in rural areas who said, I'm not prescribing opioids at all anymore. So doctors would cut people off immediately because they were worried about DEA coming in, and they were worried about getting in trouble. And a lot of those people went to seek opioids in other places. And we ended up in the mess that we're in right now. Thought it would be interesting just to show deaths in South Carolina. And the top is opioids altogether. This brown line right here is synthetic opioids. That's where your fentanyl and all those others come in. And you can see opioid overdose deaths are not going down. They're going up, and they've really gone up. And what's driving a lot of that increase is synthetic opioids, not so much prescribed opioids anymore. So we've got kind of a different problem on our hands. But what I'm here to talk about basically is what we can do about it and how we can treat it. And I'm a pharmacologist and a psychiatrist. I do a lot of studies of medications, and basically we have medications. I'll talk a little bit more specifically about what they are that can be used to treat opioid use disorders. Medication-assisted treatment, or medications for opioid use disorders, is what you hear a lot now, MOUD. And studies really dating back to the 1960s show, which is when these drugs were first introduced. And methadone is the early one that was introduced, and buprenorphine was introduced in 2000. But what you see here is that there have been numerous studies and all kinds of Cochrane reviews and whatever that show that when people are on these medication-assisted therapy, they decrease their illicit opioid use. It decreases opioid-related overdose, decreases criminal activity, infectious disease transmission, increases social functioning, and increases retention in psychosocial treatment, which is, we know medications are just part of the treatment, but if you can use medications as one way to sort of relieve symptoms, get people into treatment, then you can do the voc rehab, the cognitive behavioral therapy, the other things we know that will be very useful in terms of long-term recovery. So while there's all kinds of data that indicate that, and this graph right here is just looking at overdose deaths in Baltimore, Maryland. The red line is people started on, this is with opioid agonist treatment starting its great increase in around 2000. You can see overdose deaths go down. only 11% of those people with opioid use disorder receive these life-saving medications that are used to treat. So we have a real problem with penetration of this very effective treatment. And this is just another study that was done much more recently. This is about 50,000 patients in outpatient specialty treatment. And what we're looking at here is percent survival. So the higher number, the better. These are this darker line here. So sorry, is people with who are not on medications for opioid use disorder, and these are the people who are. So you can see the time to overdose death is increased tremendously by it's decreased tremendously by putting people on these medications. So really, these medications really do save lives. In fact, there's an 80% risk reduction in terms of risk of death from overdose when people are placed on buprenorphine. So what are these life-saving medications I'm talking about? Well, there's actually three, but we're going to talk mostly about these two of them today. One is naltrexone is an antagonist. So when naltrexone sits on the opioid receptor, it basically blocks action of any other opioids. So naltrexone can be extremely effective, but if people have chronic pain or they're taking opioids for pain, naltrexone could actually exacerbate their pain. So it's not the most, among users, most like to start if they're going to get on a medication for opioid use disorder with something that has more agonist action. So it actually sits on the receptor and at least has partial activity or full activity. So naltrexone blocks the receptor, and if you're on naltrexone, no other opioids can. So if you are on naltrexone and you shoot up heroin, you're not going to get the high from the heroin. The second one that we're going to talk about here is buprenorphine. Buprenorphine is a partial agonist, so it sits on the receptor and it does block other opiates from getting to the receptor, but it also stimulates receptor, so it produces some of the pain relief. It produces some of the mood, the depression relieving symptoms, and is much better tolerated by people than naltrexone. But the nice thing about buprenorphine is we're able to prescribe it in an office-based practice, and it's a little bit safer than a full agonist. It doesn't have as much respiratory depression, so people are less likely to overdose with buprenorphine. The third drug that we'll talk about a little bit is methadone, which has been around since the 1960s. As I said, buprenorphine was approved in 2000. Methadone has been around since the 1960s. It's a full agonist and it's highly regulated. So it's only can be administered from specialized programs, and it's very closely federally regulated, and people need to come in initially to get their dose every single day, so it can interfere with work and other things. Basically has been a very effective treatment for a lot of people. One of the reasons they control it so much, only delivering it in, and you actually have to go to the site to get your medication until you're stable enough that you've earned take-home doses, is because it does have abuse potential, and it can lead to overdose. So you don't want people in early stages of recovery taking methadone out of the clinic. And so it's really usually administered in a clinic. So those are our main options. As I said, methadone is the full agonist, been around since the 1960. Buprenorphine, as I said, partial agonist, so it blocks a full agonist. Will block heroin or other drugs. People will not be able to get high. It does have limited euphoria, limited physical dependence, doesn't cause as much respiratory depression. But again, as a medication for opioid use disorder, it definitely decreases mortality, and it's available in offices. And more recently, we've got an even better. So this is Suboxone is actually buprenorphine plus naloxone, that antagonist I talked about. And it's a abuse. This is a formulation that is made to decrease abuse and diversion, because if people shoot this up, let's say they take their tablet and they dissolve it and try to shoot it up, they're only going to get the effect of the naloxone. They'll go into abrupt withdrawal and they will not be a happy camper. If they take it sublingually, the naloxone is not absorbed sublingually, so all they'll get is the buprenorphine effect, which is exactly what they're looking for. So this is sort of an abuse or diversion deterrent formulation. And Suboxone is the main formulation of buprenorphine that you'll see prescribed for people. We now have an implant that actually lasts for 6 months. And we also have injectable buprenorphine, which lasts for about a month. This one was just approved in 2018 to 2019. So the main injectable you see used is Sublocade. The other one, the Braeburn, has had some problems in production, so it's not as widely available. But you usually have to start people first with the sublingual. So you make sure that they tolerate it. You want to make sure they're going to tolerate it and do okay with it before you put a month's worth in their system. But the nice thing about these injectables is that it's one shot and it lasts a month, and people report good relief of symptoms for a full month after the shot, so they don't have to come in every day. So any questions right off the bat about the medication? So I was going to go and move on to talk about this new, this initiative that we've been involved in for the last couple of years in collaboration with Deotis to really expand medication use for opioid use disorder in the state of South Carolina. So this is a partnership between MUSC and Deotis, funding from the federal government, 21st Century Cures. And basically our main agenda is to improve access to evidence-based treatment and just evidence about pain management and opioid use disorder throughout the state. And it's a multi-pronged initiative. And basically, one of the things that we recognized early is South Carolina is a very rural state. And so we really needed to develop strategies that were going to be useful for reaching rural areas. You know, we've got multiple rural counties, 26 counties share 233 doctors. Many counties have only 1 to 2 physicians per 10,000 patients. Or 10,000 people in the county. And so we were interested in, using telehealth to deliver. So it's just not cost effective. And a lot of the drug and alcohol treatment programs in these counties had no access to physicians. So you can imagine that's a good reason why a lot of people weren't on medications for opioid use disorder. You need a physician or a physician extender in order to evaluate people to see if they're appropriate. And so we wanted to be sensitive to our rural population and see if we could really extend evidence-based treatment. And one of the things that we're doing is academic detailing. And we have a group of pharmacists in this case that basically they go out and give face-to-face, or now, as you can imagine in COVID, it's been virtual, but they'll make appointments. And we're mostly focusing on primary care clinics or primary care practices. We give face-to-face education delivered by trained healthcare professionals. In this case, it's PharmDs. And what we usually do, because we know not everybody's interested in treating opioid dependence, but in primary care practices, they need to know about responsible opioid prescribing. They need to know about how to evaluate people for risk for opioid use disorder. If they were interested in treating opioid use disorder, we will give them training in how to use buprenorphine or help them to refer people to practices or where they are treating opioid use disorder. So basically, through academic detailing, we've reached practitioners throughout the state and at least tried to give them the tools that they need to better manage pain and better recognize people that have opioid use disorder and make the proper referral. But we're also very interested in using telehealth in two ways. One is to actually provide care to rural communities where you just can't have, if you're only going to see one or two opioid dependent people in a practice a day, you don't need, or it's not cost effective to have a practitioner or a mental health provider on site who knows about it. But if one mental health provider through, or addictions care provider through telehealth can be serving 6, 7, 8 practices in rural communities, I mean, you could really make that cost effective. The other way we're trying to use it is to provide education. So ECHO is a way of it's a telehealth mechanism to get providers together, either physicians and practitioners, or now we have an ECHO for peer group. So once a week, somebody does a didactic presentation. It might be on how to use buprenorphine, how about the new injectables, something like that. That's CME accredited. And then somebody presents a case. It could be somebody from the outlying areas. And in fact, it usually is. And then there's a discussion about the case with everybody on. So we do one ECHO a week that is for medical practitioners who are treating opioid use disorders, and another that is for peers, because we've been using peers have been providing a lot of care for us in emergency rooms, and a lot of bridging from primary care and emergency rooms to the addiction treatment setting. And they, as always, they get into there's complex situations. There's cases they'd like supervision, they'd like the input from their other practitioners about. So it's been a very lively weekly educational endeavor that we've been. So this is just ECHO. ECHO was started at the University of New Mexico for treating hepatitis. Again, the idea is that there's one specialty center, and they use this telehealth to really provide specialized care to rural communities. And in this case, our ECHO is focused on opioid use disorders and treating that. The other big initiative we have, it's going on in 7 ERs right now, we're hoping to expand, is really being much more aggressive about assessing and treating opioid use disorder and other substance use disorders in the emergency room. But emergency rooms are really an incredible sort of petri dish for giving you a glimpse into the, look at emergency rooms in COVID. I mean, they've provided so much information about what's going on, but it really gives you a glimpse into the evolving edge of an epidemic. And so one of the things we first saw, the reports of more fentanyl, more carfentanil, illicit opiates, that started coming out of the emergency rooms first. 10% of those people who present to an emergency room with a non-fatal overdose are dead within a year. So this is a very high-risk population. If you could capture these people in some way and intervene, this is a very important population. They're high risk, important to intervene on. And so what we've been doing, we have peers in the emergency rooms, in 7 emergency rooms now, and we've got providers, the medical providers at all these emergency rooms are able to prescribe buprenorphine. And so when a patient comes in with an overdose, or in another way that they're screened and we realize they have maybe they're coming in seeking opioids, pain, out of control pain, the peer will do a screening, brief intervention, talk to them about if medications are appropriate, they'll talk to them about medications, and then they'll get the prescriber involved then. But and we usually try to prescribe for them in the emergency room with a next day appointment for treatment. And often the peer is providing that bridge to treatment. The peer is the one that makes the phone call the next day, makes sure that they get into treatment. And we've screened, like 50,000 people at this point. This has been going on for a couple of years. And as you can see, 78% of those that got their came in with an overdose, got buprenorphine in the emergency room, they were still in treatment 30 days after their ED visit. So if you kind of provide this concierge service, you treat them in the emergency room with something that's really going to relieve their symptoms, and then make sure they get into treatment the next day. It's pretty amazing what an impact you can have on a population that's extremely high risk. And so I guess just to conclude, the opioid crisis is complex. We need multi-pronged solutions, multidisciplinary solutions. We need people from all parts of society, not just the medical profession, needs to be involved in trying to help us solve this. Certainly for physicians and practitioners, education about pain management, recognizing addiction, appropriate opioid prescribing. We need to not only do that for practicing physicians, we need to build it into the curriculum for our trainees. We really need to destigmatize addictions in whatever ways we can so that people will be willing to come to treatment. And then we need to improve the access to treatment with more programs, more medical involvement, because we do have medications that work. And then finally, insurance or financial coverage for treatment has certainly been a huge problem in this area. And with that, I will stop my screen sharing and see if there's any questions or discussion.
Thank you so much for that, Dr. Brady. You covered so much information so quickly.
Yeah, I hope it wasn't too quick, but
no, it was great. I appreciate so much the work that y'all are doing. And every time I hear about the ECHO project and the ways that we're supporting folks in rural communities, that's so essential.
It's interesting. We've got some regulatory hurdles there that we're really battling with because, we couldn't prescribe buprenorphine without seeing patients first. Then when COVID happened, all the regulations were released were decreased at a federal level. And what we discovered is that you could do this via telehealth, even without the initial visit. But now that, when we were in a state of emergency, telehealth was fine. Now that we're back into a non-emergency, we're sort of, bumping up against regulations about the use of telehealth in these for these patients. So.
Well, I think it's so interesting. I have some questions, but I want to take a minute and let our panel introduce themselves. And to our audience, folks, you are welcome to put some questions for any of our presenters in the Q&A, and we're happy to answer them as we go along. I'm wondering if we can go ahead and have our panelists introduce themselves. I know, first I have to say, I promised that we were going to have one of our alums to share his experience with being on MAT and how that was a part of his recovery journey. And he got pulled into a law school class that had been canceled because of COVID. So he will not be joining us. We're going to hope to schedule him for a future Arise session. But I think that our panelists will help be able to represent some of the other perspectives that are represented. So maybe if each of y'all could introduce yourselves and tell us a little bit about what you do and your involvement with how you maybe connect to MAT. Jennifer, you're on my screen first. Will you go ahead and start and introduce yourself?
Yeah. Hi, afternoon, everyone. Dr. Brady, I really appreciated your clear and concise kind of overview about medication-assisted treatment and recovery. Thought it was very helpful. I am Jennifer Weller-White. I'm the treatment director of outpatient services at LRADAC across Lexington and Richland County. So for those of you who don't know, we are the local commission treating substance use disorders here in the Midlands. And basically all of those things that Dr. Brady was describing about what treatment and medication looks like, our facility is actually doing the practical application of those things. So I'll be glad to kind of share on that when it's
that's wonderful.
Great. And Bobby, you're next. And I think you've got a friend.
I do have a friend. Believe it or not, I still have a friend, and he's been friends for 30 years, and we're still friends. He speaks to me. So, I'm Bobby Brazel. I'm executive director of Midlands Recovery Center in Lexington. We're an RCA, so we utilize peer support. I'm also an interventionist for Arise Intervention, trained under Dr. Judith Landau. And this is Ryan. Ryan is a person in recovery. He is like me. He's struggled for a very long time. We've played music together. Our lives have been parallel, and we both had experience on MAT. I've been on Suboxone myself. I did a Vivitrol shot 4 months when I left my 12th treatment center, and I was lucky number 12. So it took me 20 years to get 7 years of sobriety. So I was a little hard-headed, I guess, or committed, one or the other. So we both have experience with MAT, and Ryan is new in recovery. He's coming up on his first year of sobriety, and it's really good. It's really good to have him here, because we almost lost him last year, and it's a great thing to have him here. So he's also alumni of Carolina, but I don't hold it against him since I'm a Clemson fan. But that's
Yeah, Ryan. I'm an alcoholic and a drug addict. Habit. I've been to 9 different treatment centers in the course of my struggle. And I've done MAT several times, everything from methadone to Suboxone, Subutex. And I've done the Vivitrol shot as well. My most recent treatment center, I got clean at Charleston Recovery Center, and currently working there as a staff member. That we do it's 12-step based. We work out of the big book, peer-on-peer recovery. That's my short bio.
So in June, Ryan will be trained and certified, and he'll be in my class. I'll get to do that, and that'll be a very important day for both of us, I think. So, he has the ability to reach people I can't reach, and vice versa. And I think that's the beauty of it. And not a one size fits all. I had a very bad experience with my MAT not because of the medication, but because it was new, and it was like in 2010. I was not even allowed to be in part of the IOP program because I was on MAT that was prescribed to me by the doctor of the IOP program.
Wow.
I mean, and that's true. And then he lost his license because apparently he liked drugs as much as I did. And so I found out on a Saturday that I no longer had a doctor or a prescription. And I was director of operations for Richland County EMS at the time. And so that meant that I would be at work Monday in withdrawals. And I had to figure out a way to make that not happen. So my plan was to detox myself using pain pills, and I knew it was going to work very well. And it worked so well, I was on the news a week later, and for fraudulently obtaining narcotics. I am no longer a paramedic. Dave Brown calling that kind of thing, that's just kind of how it is. But
thank you both for being here and for sharing. I want to let Kat introduce themselves, and then we can we can start with some questions and some conversation, because I think we want to keep talking about this. But Kat, will you introduce yourself first?
Yeah, absolutely. I am Kat James. I am the Gamecock Recovery Coordinator at the University of South Carolina. To provide peer-based recovery support, including meetings, coaching. We do social events and sort of anything that we can think of that will help students in recovery feel connected to the university and to one another, and get the care and support that they need. And I'm a person in recovery myself. My story is a
really different, I think, than Bobby and Ryan's. But I'm really grateful with our program at the university. We support all pathways. We really encourage people to find whatever works for them. And so I'm always really grateful to be around folks who are finding what's going to work for folks, being really adaptive in these ways to say everybody has these individuated needs, and so how is it we're going to change what we're providing or what we're offering and what we're thinking and talking about as a community as well, to be able to support stuff. And congratulations, Ryan, on your upcoming year.
Well, so one question that came up for me as Dr. Brady was talking, and we've got a lot of our students on the audience right now. And so I've been talking with a lot of them this week about opiates, about the epidemic, and there's just, they don't know as much as I thought that they did. So I think this is a good start to some of that conversation. Dr. Brady talked about treating the symptoms with MAT. And I think that's an interesting way to think about it, Dr. Brady, because we think about opioids as treating pain, but MAT treats a different set of symptoms for folks who are in early recovery. And so I don't know, Bobby, maybe we can start with you and Ryan talking about what's that experience like? What are those symptoms in early recovery from an opiate use disorder that that these medicines help?
I will say it was the best thing that ever happened to me was when I was told that the substance use was the symptom of my problem. Okay, like the drugs I was using were the symptom of the problem. There was an underlying issue that needed to medicate, first of all, and that I was treated as a person with a medical disorder and not as a person with a moral failure, because I tried repeatedly and couldn't understand it. And I just, and I'd had a bad experience with MAT because I'm at 160 milligrams of methadone, and I could not grab my tail with both hands, and I would not be able to hold a conversation because I got to choose when I was at a therapeutic level. But that was not the medication's fault. Okay, that was, it was early on, and in retrospect, all those things, even if it was a negative experience, it kept me alive long enough to where I could enjoy my abstinence-based recovery today. And without it, there would not be a me and there would not be a MRC. And, I'm grateful for that. Even if I don't agree with it, all of it, I don't disagree with the medication at all. I think it's a very helpful tool, but it doesn't equal recovery. There's a lot of things that make recovery possible. But you have to be alive to get it, and so I'm a firm believer in that, the harm reduction.
But yeah, I would agree with Bobby. Without the MAT, I wouldn't getting alive long enough for all this planted where I'm at now. And I also think that, if the drug is used as prescribed and responsibly, it certainly has a significant place in recovery. However, I'm speaking as an addict, and when I'm in active addiction and, I'm exhibiting those addict behaviors, I'm going to find a way to beat the system. So, Suboxone especially afforded me an opportunity to manipulate it. I was able to take the Suboxone or Subutex when I didn't have dope. I could lay off for 24 hours and I could shoot some dope. And that was a cycle for me. And once again, that's not the drug's fault. But I think, for me at least, and in my experience dealing with other addicts, we're not the most honest folk when we're in active addiction. This may come as a shock.
I've heard too. I don't have any personal experience.
And so, I didn't have the willingness at that point in time when I was prescribed the medication to really take recovery serious. You know, and it took I had to be surrendered by the needle and then surrendered by life on life's terms before I could really begin to take a program of recovery serious, you know, and so, yeah, I'm grateful that that you know, Suboxone and methadone, Subutex, did keep me alive long enough for me to really, really embrace the program of recovery. And, you know, for me, like I said, it's a 12-step base, embrace spiritual principles. As Bobby stresses all the time, there's so many paths to recovery.
I went from a staunch like anti-MAT to now I'm a community distributor of Narcan. We give out fentanyl testing strips. We do a lot of education, and I'm very involved in harm reduction because, you know, it really was a epiphany whenever I was told that I was alive. What are the chances that I would be alive to enjoy my recovery today had it not been for those medications? And that was, so now the focus is we got to keep people alive. So whatever it takes, that's what you have to do.
So true, Bobby. So true. Juliana put a good question in the chat, which I think is similar to kind of what we've been talking about. Dr. Brady mentioned that MAT is underutilized. So what's the reason, right? So why is it underutilized? Is it hesitancy? Is it access? Like, what are some of the reasons why it's so underutilized? Juliana is one of our grads who's from New York, where it's much more maybe accepted or less stigmatized to be on MAT. So thoughts, what are the hesitations for doctors, providers, for patients?
Well, we don't have enough prescribers, that's for sure. So you do need to take some extra training in order to prescribe it. And when we were providing that training for free and trying to go out and get more prescribers involved, a lot of primary care doctors said, I don't want to do that. I don't want my waiting room full of people with addictions. So there is a huge stigma around addictions, and it's prevented us. There's, you know, every primary care doctor could and should prescribe. Every psychiatrist could and should be able to prescribe buprenorphine, but a lot of them don't. So that's on the provider side. I think there's probably there's issues of payment, you know, until we had the Cures Act, a lot of insurance companies, in South Carolina, where we don't have Medicaid expansion, there's no coverage. In New York, there's coverage for medications for opioid use disorders. That's another one. And then some patients actually, or I'd love to hear Bobby and others talking about that. I think there are patients who say, no, I want to do it on my own, you know, whether that's because something they heard or their family say, I'm not sure, but there's resistance from a number of different sides, I think.
Ryan and I were just smart enough that we were convinced that we could find a way to use it successfully, that we did not have to quit using drugs at all. We just had to learn moderation. And that I don't know, I can speak for both of us. It never worked. And I think honestly, like Ryan said, the medication, there's a lot of stigma behind it. Even, you know, in 2010, I had to hide the fact that I was taking it so I could be involved in the IOP program. Now it's changed to there are IOP programs, and you have to be involved in that to get the medication. So that's how much it's changed. That's progress. But that was just only in 2010. So 12 years ago, I couldn't even go into a meeting, NA or AA meeting, and admit that, because they would escort me out, you know, with a very strong recommendation to never return. And that's just true. And that's still big in our own recovery community.
having trouble hearing Brian.
Yeah. It's a moment.
Yeah, I was just, saying, reiterating what Bobby said, that in the 12-step community, the MAT is still very, very stigmatized. It's become a little more acceptable, but that's really going to vary from meeting to meeting. I think as a whole,
People believe that it somehow diminishes their pathway of recovery because they've chosen it the easier, softer way.
Right.
And I do waiver trainings for second-year med students through USC. I help with Dr. Goodman, and we help start the IAC team, the inpatient addiction consult team, where we make relationships with people while they're in the hospital, hopefully to connect them with recovery services afterwards. But it's a hard fought battle because our population has no funding for any of it and a lot of barriers.
Jennifer, I feel like the RADAC has changed kind of some of their approach to MAT in the last 5 to 10 years. Would you like to talk about this from kind of the provider perspective?
Yeah, we are lucky enough to have 5 providers of MAR services. We like to refer to it as MAR, medication assisted recovery, because we know that that is a process of recovery that doesn't just stop when people have completed their treatment services within our program. So we have prescriber appointments Monday through Thursday for people to access care. We do require them to be adherent to some type of treatment engagement, whatever that recommendation is for their level of care. But even after people have completed their treatment with us, we do have maintenance phase programs where people can stay on MAR through us and through financial assistance through DAODAS, which makes their medication free and accessible through us. And then we recently started offering Sublocade for people who are more of a part of the transient population. So that way it was more accessible for them to be able to get their medication. But it was a very large switch, I think, not necessarily for our primary treatment services, because we really do believe in multiple pathways to recovery. And if people have been unsuccessful due to chronic recurrences in their use, we know those are people who are very much eligible and good candidates for MAR. But I think that a lot of our paraprofessionals, our peer support staff members, really came from a background, and I think Bobby can kind of speak to this probably, of thinking that abstinence was really the only path towards recovery, and that if you were participating in an MAR program, that you were substituting one substance for another. And what we all know and what the research has told us is that that's not the case. That's actually what can get people into a pathway towards long-term recovery. And I think that a lot of people had also had very negative experiences and opinions of methadone treatment programs. And so we're very worried that commissions across the state were suddenly going to turn into methadone clinics. And I think that was a worry for lots of people, and maybe for good reason. And what we've seen happen is that that's not the case. We've gotten a lot of people into sustained recovery. I think we've all saved a lot of lives through making MAR a lot more accessible to people.
And there's so much truth to that. I mean, I can just say, our pilot project that we started with the Prisma Health was utilizing while they were inpatient for endocarditis, osteomyelitis. They had heart valve replacement. They were put on MAT and connected with a recovery coach while they were in the hospital. And our results got published in the American Journal of Medicine. So I didn't realize that was important until, because I'm like, okay, cool, is that good? And I realized that they thought it was really good and my name's on it. I'm like, wow, that's cool. So it afforded us an opportunity to expand the program. And unfortunately, the hospitals, sometimes they are competing with one another inside the same hospital. The upstate, they're in 8 hospitals. Here, we can't even go in the hospital to visit because we're not employees of the hospital. But victims advocates for, if a woman's assaulted, they're not employees of the hospital. So we're advocates as well. I mean, I don't know how, and to be honest, I was doing this presentation yesterday, and a lady, after I spoke, she said her exact words were, "I am not sure why you were chosen to spoke, and I cannot understand what you contributed to this at all. And your contributions could have been limited to a couple of sentences in a comment section." And her colleagues ripped her, Dr. Margaret Rextalis, who I've co-presented with several times. They were, I mean, I didn't have to say anything. I was very polite and I understood, and that's someone who will be treating people like myself. And that was her opinion of me. And that's recognizing that stigma is everywhere is just important, and we've got to do better.
Thank you for sharing that, Bobby.
Yeah, that's
one of the reasons we're here, right? Is to break down some of that stigma. So this is my chance. Kat's nodding. I did put a couple of shameless plugs as we're nearing close to time in the chat. So we do a recovery ally training on campus for faculty, staff, and students who are interested in learning more about how to support folks who are in recovery. We talk about stigma, we talk about language, talk about some of the ways that if you're not in recovery, you might not be aware of how all this works. And so students and faculty and staff can sign up for that. We also do a speaker series once a month where you get to hear someone share their story and their experience. And we know that that does so much to help break down some of the stigma and have some of the conversation about, thank you, Hannah. Our Rise series really helps to bring the stories home and for us to hear from Gamecocks and former Gamecocks and community folks who are in recovery to share their story with us. So we hope you'll join for that. I did put a couple other tags in there. We've got conference registration scholarships available. Jason Kilmer is doing a fantastic presentation about cannabis in a couple of weeks that everybody should go to because he's amazing. So feel free to check all of those out. Folks, let's wrap up with maybe one or two thoughts. If you had all the money in the world, if you could do anything you wanted in relation to MAT, what would you do? Where would you spend your first million? Dr. Brady, we'll let you go first.
Well, that's a great question. I wish I knew some way to use money to decrease stigma. And I think maybe one of the ways stigma is decreased is by, celebrity endorsement and more families sort of coming out and talking about their own experience. Because if you can relate to it, it happened to a family that's just like mine. So if I could somehow use that, I'd either use it to tear down cost barriers for anybody that can't afford treatment, or I would attack stigma in a big way by trying to get celebrity endorsement and families and, just do an advertising campaign to really try to break down some of these misconceptions people have about addictions.
Jennifer?
I guess to piggyback off that, we're very lucky right now to have the money in the state, and who knows how long that funding will last, to make MAR and treatment accessible by being able to fund that for our patients for up to a year and a half. But then we find that some patients are very reluctant to be transitioned to another provider because of the cost. So I would love to just continue to put more money into that, and to also other forms of harm reduction. And I don't know, maybe sometime in the future, we'll see need exchange programs and things like that not be illegal in our state, to continue to help with reducing stigma and increasing safety.
Pat, any thoughts on this one?
Yeah, like what would we do? What would Gamecock Recovery do is the way of trying to frame it, because there's innumerable ways to spend this money. And also everybody else on this call is smarter than me about a lot of this implementation efforts, I think. But one of the things that we really see in Gamecock Recovery is the way in which relationships is healing to people. And so, and this is actually like lynches off of a little bit of what Bobby is talking about, but connecting that peer support with the availability of MAT and with, you know, harm reduction strategies, and building that relationship piece between people who have had these lived experiences and people who are not sure what the future might hold for them or for their loved ones, I think is where Gamecock Recovery might be able to like have a role in spending that money and having an influence.
Community, right? We're all about community. Okay, Bobby and Ryan, close us out.
And honestly, we have to do exactly what Dr. Brady said. How did you change the landscape of how people saw HIV? You changed the language and you changed the way, but it did not affect but a certain population. You had to show them that it affected everybody. Okay, and that's the same thing. It affects taxpayers. It affects everything. And you have to change the language. I've stomped on Ryan's toe about 12 times every time he says addict or addiction, because I teach in my class that that's not medical terminology for what you have. You have substance use disorder. Nobody cares or feels sorry for, has compassion for somebody who is an addict, because they might steal your purse or rob you right there. I'm in long-term recovery from substance use disorder. Okay, so we have to change the way people see us, and nobody can do that except us. We have a responsibility to change the landscape.
Thank you for that. I think that's a great way to finish us up. So thank you to all of our folks for joining us. Thank you for Dr. Brady for the great information. Really appreciate everything that was shared today. And we will be back the first Thursday in March. We're talking about the overlap of mental health and substance misuse, and particularly cannabis use and suicide, with the folks from Missouri Partners of Prevention. So hope you will join us for that in a month from today. Thanks to everyone.